下一位讲者是来自于我们泰国的Tanitra 教授。Okay, the next speaker is a Professor Tanitra Tantitamit, and she is from the Princess Mahar Kakri Sundari Hall Medical Center. And today, her topic is complications of radical hysterectomy. Let's welcome.
Thank you very much for your kind introduction. Thank you for having me in this conference again. Good afternoon, everyone. After we have updated about the data of radical hysterectomy and the technique of this surgery, today I would like to focus on its complications. Nowadays, thanks to the perioperative care and surgical evolution, the complications of radical hysterectomy have been decreasing. The mortality rate is less than 1%, and the mortality is acceptable, is less than 5%. It is proportional to the radicality of the surgery and the extent of lymphadenectomy. We have divided the complications into intraoperative, acute post-operative, and chronic post-operative complications. Intraoperatively, most common complication is intraoperative hemorrhage. It could occur from radical hysterectomy or when we perform the pelvic lymphadenectomy. When the vascular injuries occurs, it can repair by direct pressure using hemocrypt, socialization, or sometimes hypogastric uterine artery is required. The internal organ injuries such as the ureteric injury, it is recognized intraoperatively in less than 1%. If ureteric injuries occur, the procedure like ureteroneocystomy or ureterostomy is required. Cystotomy or enterostomy could occur occasionally. To repair enterostomy or cystotomy, we can direct repair by double leg closure. Acute post-operative complications usually means the complications occur within 30 days after operation. The most complication is febrile morbidity or fever. It can occur by pulmonary infection, atelectasis, urinary tract infection, wound infection, pelvic cellulitis, or fasciitis. Bladder hypertonia is also nearly universal, and I will discuss this problem in detail later. Post-operative hemorrhage sometimes is required pre-operation, but most of the cases are self-limited, and it can be treated by conservatively. The complications like urinary tract fistula or thromboembolic event, this is rare occur. It occurs only 1 or 2%. For post-op ileus or gut obstruction occur occasionally only 1%, and most of cases can be treated conservatively. The chronic complications usually mean the complications occur more than 1 month of surgery. Even these complications occur less frequently, but it affects the quality of life of the patient significantly. These complications are lymphocytes or lymphedema, sexual dysfunction, bladder hypertonia, or ureteral stricture, especially in the case receive adjuvant radiotherapy. One randomized center clinical trial, including 12 individuals and more than 200 patients, reported the perioperative mortality rate was less than 1%. The most common complications was urinary tract infection, and it occurred almost in half of the patients. Event conversions occur in 3%, and urinary tract fistula occur in 2%. Another review of complications of radical hysterectomy reported the most common complication after surgeries were bladder dysfunction and lymphocysts, and its occur range from 5 to 15% of cases. The majority urinary tract complications, such as ureteral injury or vesicovaginal fistula, are now extremely rare and is reported less than 1%. a large retrospective trial of almost 1,900 patients. From 2006 to 2010, this study focused on major perioperative morbidity and is compared between laparotomy, laparoscopy, and robotic surgery. The results showed that the overall complications and medical complications were higher in laparotomy group significantly compared with minimal invasive surgery. For intraoperative complications such as bladder injury, urethral injury, intestinal injury, vascular injury, surgical site complication, and VTE, these complications were not significantly different among three groups of surgery. And this study concludes that minimal invasive surgery is safe and often associated with a lower rate of complications than abdominal approach. A systematic review and meta-analysis through 2015 compared between robotic and abdominal surgery, including 15 studies, and compared between robotic and laparoscopic surgery from 11 studies. The results showed that the patients in robotic group had significant lower overall complications than abdominal surgery, and robotics also show a lower incidence of wound infection, fever, urinary tract infection, but it has higher risk of vaginal complications. Compared between robotic and laparoscopic surgery, there was no difference in overall complications, intra or post-operative complications, and it had lower trend in conversions with robotic surgery. For time to normal residual urine, it was not significant difference. This data concludes that robotics has a positive effect in reducing overall complications than laparotomy. Compared to laparoscopy, the current evidence is not enough to conclude its clinical safety and effectiveness. Another systematic reviews and meta-analysis focus on nose-sparing minimal invasive radical hysterectomy. Compared with non-nose-sparing minimal invasive radical hysterectomy, each arm consists of 350 patients. Almost half of patients in each group received neoadjuvant chemotherapy. The results, the outcome of intraoperative complications and severe post-operative complications were similar among between two groups. The outcome of purifying dysfunction, this study focused on voiding dysfunction, sexual dysfunction, and rectal dysfunction. The results show the patient in the sparing group may be superior in reducing these complications. Now, I would like to focus on the complications that affect the quality of life of the patient. Usually is the chronic complications after surgery. The first complication is cancer-related lymphedema. This complication is the result of disequilibrium between and that of lymphatic drainage system. The study showed that drainage from superficial and deep lymphatic vessels is interrupted. It could be caused by the surgery, radiation, trauma, or infection. Greater than 50% of this problem increase in risk of cellulitis. The well-known risk factor is obesity. And recent study shows a polymorphism of KDS gene associated with breast cancer-related lymphedema. So genetic characteristics may be explained why this problem occurs only in some patients of us. The gynecological cancer treatment is associated with lymphedema of 25%, and most of cancer are cervical and oral cancer. Even the sentinel lymph node biopsy could decrease this incidence to lower than 10% in overall gynecological cancer, or only 4% in cervical cancer. But it could not eliminate this risk. Therefore, before the operation, we should discuss about the probability of this complication to the patient. The current standard treatment of this complication is compressed decongestive therapy. From previous study, it could decrease the lymph volumes and improve the quality of life of the patient. And surgery is used for only patients who are refractory to CDT only. The next complication related lymphadenectomy. This is the lymphocyte or lymphocyst. This is the result of the volume of lymphatic fluid is too large to be resolved completely, and this fluid collects in thin vortices with or without septa in the gas. I and Professor Holmes did a review about the potential risk of this complication and the way to prevent this complication. The previous study focused about the risk, including the type of malignancy, body mass index, extent of lymphadenectomy, total numbers of resected nodes, metastatic nodes, surgical approach, and post-operative radiation therapy. But the results show this inconclusive. There is no significant risk to predict this complication. However, the way to prevention now is recommended to open the peritoneum and avoid pressing a drain. There are two strategies which show promising results. These are biological groups are using new energy source, but the study shows it could decrease the incidence of asymptomatic lymphocytes of patients. But this is only small sample size of study. The largest and randomized control trial is needed. Next is the common problem is the effect on sexual function. The negative effect on sexual function, we believe that it occurs from a damage to the local autonomic nervous system, a resection of paracarpium, a shortening of vagina, and loss of organ function. One study including a patient more than 172 with lymph node negative early-stage cervical cancer. The patients were assessed by a questionnaire at different times after surgery. They reported that they had sexual dissatisfaction at 5 weeks after surgery, severe dyspareunia at 3 months, severe orgasmic problem at 6 months, and these problems affect as 2 years. The patient also reports long-term lack of sexual interest and insufficient vaginal lubrication. Is there a difference in it according to the extent of surgical radicality? One study compared sexual function 1 year after surgery in the patient performing radical vaginal tracheotomy, radical hysterectomy, and the control group. The results show the patient in radical vaginal tracheotomy tend to have persistent sexual dysfunction during 1 year after surgery. The sexual worry and sexual distress scales were more frequently among broad treatment than control group. Another paper focused on the patients who performed cervical colonization compared with radical vaginal tracheotomy and radical hysterectomy group. The result was similar to previous slide, only on the colonization group, no increase in the proportions of females with sexual dysfunction, and no significant difference between radical vaginal hysterectomy and radical hysterectomy group. Regarding nerve-sparing radical hysterectomy, a study evaluated morbidity before and 6 months after surgery, comparison between type C1, C2, and type C radical hysterectomy. The results show the patients who perform nerve-sparing have less negative effect on sexual function than others, and no difference so far between type C and type D radical hysterectomy. As we believe that this problem may occur from the shortening vagina, one study focused on the patients who underwent peritoneal or vaginoplasty, and the study evaluated morbidity before and 6 months after surgery. The patients, about 30 in each group, received the performing vaginal extension versus without extension, but this study failed to result in improved sexual function in intervention group despite an average difference of about 4 centimeters. For route of surgery, a small study comparing between laparoscopy, laparotomy, and control group. The results showed the patients in laparoscopic surgeries were lower in all 6 domains. Comparison with control group. The 6 domains were discharge, arousal, lubrication, orgasm, satisfaction, and pain. But the patient in laparotomy goes lower than control in only 3 domains, which are arousal, lubrication, and orgasm. However, comparing between laparoscopy and laparotomy, there was no difference. Conclusion about the effect of sexual function. Research in this field is hampered by lack of RCT, and most of study has a small sample size. Now, to conclude from previous study, there was no clear benefit in terms of improved sexual function in patients undergoing radical vaginal hysterectomy, but seems likely for nerve-sparing technique. The individual's life, oncosexuality care is essential, even there is no study in this issue yet. The next complication is quite common. I would like to talk about the bladder dysfunction after radical hysterectomy. It's caused by injury to nerve supplied to his uter muscle. At first, it's called bladder hypertonia. And then it's gradually to bladder hypotonia. Usually, we insert the solar catheter about 3 days, 5 days, or 1 week. Most of patients can return to work within a few weeks, but approximately 5% of patients, this problem may persist for a long term, and long-term effects at 1 year after surgery. The most patients suffer from decreased bladder function, and bladder and urinary incontinence, such as urge incontinence, mixed incontinence, or third incontinence, have been reported. What is the risk of this problem? The risk of short-term bladder dysfunction has been studied. One study clarified the risk for resumption of spontaneous voiding following nerve-sparing radical hysterectomy on post-operative day 7. This study consists of the patients in early-stage cervical cancer. More than 700 patients underwent type C1 radical hysterectomy from 2006 to 2016. The results of multiple asset analysis showed that the patient with a large tumor size, more than 4 centimeters, post-operative urinary tract infection and surgeon experience has a higher risk of voiding dysfunction. For long-term bladder dysfunction, another study focused on bladder compliance at 1 year after surgery. To clarify the risk factor of persistent bladder compliance, this study conducted in patients more than 100 underwent radical hysterectomy with intention to preserve the autonomic nervous system, and the risk factors were non-nerve sparing surgery, adjuvant radiation therapy, and the patient who had voiding with abdominal pressure at 3 months after surgery. Adjuvant radiotherapy has highest odds ratio at 10:3. The Cochrane Library, published in last year, concluded about 26 studies, and this study focused on nerve-sparing radical hysterectomy. Included patients more than 200 with early-stage cervical cancer, comparing between nerve-sparing and non-nerve-sparing radical hysterectomy, and the results showed that nerve-sparing surgery had shorter time to post-void residual volume of urine, and lower volume of post-void residual urine ratio 1 month following operation. A systematic review and meta-analysis published in last year comparing bladder dysfunction in laparoscopic nerve-sparing radical hysterectomy and laparoscopic radical hysterectomy. These studies proved the benefits of laparoscopic nerve-sparing radical hysterectomy that the patient in this group has more satisfactory maturation, shorter catheterization time, shorter recovery to normal post-void residual urine time, better results in urodynamic assessment, and less frequent in urinary retention, nocturia, dysuria, urinary incontinence frequency, and urgency. Lastly, I would like to summarize my talk with this slide. With improvement in surgical technique, prophylactic antibiotics, thromboembolic prophylaxis, and advanced in clinical chamber disease. This resulted in lower perioperative morbidity. Minimal invasive surgery is associated with a lower rate of complications than abdominal radical hysterectomy. Comparing between drastic and laparoscopic surgery, the correct evidence is not enough to clearly determine its clinical safety and effectiveness. And non-sparing minimal radical hysterectomy is superior in reducing pelvic floor dysfunction rate. Thank you very much.
Okay, thank you very much, Professor Tanitra. A very wonderful speech and share the experience why we should have this surgery complications and how to deal with it. And here is a question. You know, the bladder dysfunction you mentioned is very common in the patient who has received the radical hysterectomy, even they have received the nerve-sparing surgeries. And how do you deal with this kind of patients in your hospital if they have the persistent bladder dysfunctions?
In my experience, I had some patients has this problem, but only short-term bladder dysfunction. I just insert the folic catheter maybe 1 month, but I never met for the long term, 1 year or 2 years. I never met this problem.
Okay. Thank you very much.
Thank you very much.
Thank you. And here we have a certificate for you